3 p.m. Roll call, Mary.
Pat Rooney.
Here.
Marcia Cox.
Here.
Mark Nixon.
Here.
Hal Christensen.
Here.
Carrie Thompson.
Here. Can we stand for the Pledge of Allegiance in a moment of silence, please? I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
Thank you. We will now have a call to the public, and I have one from Leanna Fuentes.
Would you like me to stand or sit here? Or?
Stand if you would, because it is recorded.
Madam Chairperson, Madam Chairwoman, and EBT Board, my name is Leanna Fuentes. I spent the majority of my career here in Lake Havasu as a teacher. I worked at both middle schools and at the high school, and I retired in 2014. The reason I'd like to have called to the public today is I have two concerns. My first concern is that we, the retirees, no longer have a representative on the board that I'm aware of. We had Colleen Panko, we were very pleased with her, and now I don't feel, and there's several of the retirees that said, yeah, go and represent us all, but I'm saying you guys need to come and represent yourself too, so that EBT is aware that we have a concern that we no longer have a rep. That's my first concern. Now, I did talk to Mike Murray, and he said Carrie was representing the staff as well as the retirees, and nothing against you, Carrie, but we feel like we should have a representative from our own group of retirees. I think there's about 50 of us now, or they keep falling off the rolls year by year. My second concern is the increase in premium. When I retired in 2014, I stayed with the school district, one, because I loved my job, and two, because I was a dedicated teacher, thinking that when I retired, one of the perks would be that my insurance would be covered until I went on Medicare. So the first year I got it covered at $0, and I understand what the rule was way back when the school board said you'd pay up to $3,000, and so that was covered. My first year was covered at $0. The next year, it went up $41. I was a little upset about that, and I thought, well, whatever, it's $41. Last year, it went up to $145, and this year it went up to $155. Now, I don't expect the staff to have to pay for their insurance, but I'm big about loyalty, and I just think, the retirees were loyal to the district. You're going to have less and less of us as we go on, because I think after 2005, you can no longer get school district insurance. So that's my big concern, is the way that the rate, jumping from 0 to 45 to 145 to 155. That's a huge increase. I'm not sure why it's on the backs of the retirees, because nobody else that I can see is getting an increase. Or if it's an increase, it's getting taken care of. So those are my two concerns. I understand that you can't answer my questions, but at least it's put out there and it's on an agenda, or it's documented on a paper trail that those are some concerns. Thank you.
Any other calls? All right. We will move to 2.1. Ratification of the approved minutes from the May 17 trust meeting. Do I have a motion to approve the minutes?
Second.
Any discussion? Mary?
Hal Christensen.
Yes.
Mark Nixon.
Yes.
Marcia Cox. Yes. Pat Rooney.
Yes.
Carrie Thompson.
Yes. .2 approval of the LHUSD EBT audit report. Dave?
I have heard nothing completely back from Melanie Askew, the auditor. I sent her all the information I could gather from Gill's Bar in terms of payments categories. She has not responded back to me since I sent her that information. The last email I sent came back that she was out of the office. So she was still working on gathering all the information, the extended information that she had asked for. I'm sure she's working on it, but she has not finished it yet. And I left it on the agenda in hopes that it would be ready for review, but apparently it's not. I will continue to follow it because I sent probably 3 years worth of an Excel spreadsheet of checks and data to her for her to review so that she gets the line items correctly in the audit report, which is what was being asked.
Right, 2.3, the Morgan Stanley report. Mike, do you want to handle this one?
Madam Chair, members of the board, the Morgan Stanley report for May 2017 shows a balance of $2.118 million in cash and $975,000 in investments. That's the May statement 2017.
Can you repeat those figures again, Mike?
Yes, sorry. 2.118 million in cash, 975,000 in investment seeds.
Any other follow-up questions on the report that was emailed out to the board? Okay, 2.4, 2017-18 vendor rates. Dave?
I think you were asking, if I'm not mistaken, you were asking, you seem to be saying
The
that
premiums.
the rates, the premiums, yes, and you clarified that.
Yes.
But you're seeing, I think, the dispute in what Sherry sent to you versus something else that was sent to you.
I'm not disputing, just at the last trust meeting, we didn't have accurate premium rates because it was going to change according to the vision changes in life insurance for employees. So, and then I did get emailed that, but that hasn't been shared with the board. So, and I know at, Sherry was working at the district, just so that I have a clear picture of what the premiums are.
I think it was shared.
I didn't.
You didn't get it? Okay, I have copies.
Okay.
Mary will make copies for everybody, but I was a little confused at what you were really asking for. So.
I've had a few questions come my way, specifically from retirees, and I just wanted to make sure I could look it over and see where the changes
Yeah,
went,
the
and
rates
maybe
dropped
explain it.
because the vision dropped from 11 down to $5.18 on the employee only, and then even on the dependent side. And then the dental premiums also dropped, so that impacted the overall cost. And so, yeah, there's a couple of reductions in there, but the medical rates overall went up 5%. So you got a little bit of a reduction in some areas, but another increase in the medical plan rates. So as soon as Mary gets those run off, or Kelly went to do it, I'll submit it. I'll give everybody a copy of it. But I apologize if somebody didn't get it because apparently it did go out to some folks.
And on the dependent rates, there were different percentage increases. Was that, did that happen for a reason, or?
It was supposed to be a 5% across the board.
Okay, because that's what was voted, so that's what I was going to see if the numbers, because I know I've seen a couple of different versions, so I just want to make sure.
The ones I submitted to the district were over across the board 5% increase, or maybe a little less, but right at 5%.
Across the board, 5% total, or just on the medical?
Just on the medical.
Okay.
Just on the medical. The dental rates went down, the vision rates went down, the life insurance rates went down, so it was just on the medical.
And was it ever clarified that it was the gold or silver plan? Did we ever discuss any of that?
That affects retirees only,
Okay.
is my, right? The
Correct.
silver plan, maybe you can explain that.
The silver plan only, well, the district wanted to make a little lesser costly plan available to maybe some of the retirees. So they made that decision to offer the silver plan because we had the choice, when we negotiated this last year, had the choice of the silver plan or the gold plan. Well, the employees all voted for the gold plan and the district funded the gold plan, but the retirees, to save a few bucks, wanted to go to the gold plan, they could do so and pay a little less premium. It's a little higher deductible than the gold plan, and hence the reason for the slight reduction in premiums.
So just so I understand what you're saying, the retirees were given the option to pick the silver plan if they wanted to lower their premiums?
Correct.
Okay.
Or they could stay with the gold plan if they wanted to pay the higher premium.
Okay. And were all of these premiums posted or based on this? Was this all of net of commissions? Or?
Correct.
All net of commissions.
Great.
May I ask, how much is the deductible on the silver and gold plan for the retirees?
I'm sorry, I don't have that in front of me. Let's see.
Do you know, Leanna, since
Yes.
you're retired?
9,000 on the silver and 6,000 on the gold.
The deductible? Or the out of pocket? I think that's the out of pocket.
Yes.
That's the out-of-pocket. Let's
Okay.
see here. Premiums, I don't know if I have
Seems like it was
plan design.
5%.
Kelly, can you ask Sherry if she has a copy of the gold and silver plan, please? Thank you. That was sent out to all the retirees, as I remember.
And they would have already had to choose that, right? Because it's effective
Yes.
July 1?
Correct. While we're waiting for that, Madam Chair, I do have representatives from Emeritus here to answer any questions with regard to the report that was sent out to you previously. And I got an email or a text message from Joyce Perez from Gilsbar saying she would be a few minutes late.
I'm here.
Oh, there you are.
Yeah.
Sorry.
I thought that was
Sorry.
you.
Apologize.
I snuck in.
I was looking out all over you. I apologize, but as soon as we can get, I mean, usually I would have done that in 1A. If anybody had any questions, or if either Rich or Joyce wanted to make a comment on the report, or if you had any questions on the report that went out previously to everybody, because last time you asked if I had any comments on it, so Rich is here to answer any questions, or Joyce is here to answer any questions on the reports.
And we can give brief overviews, I'm sure, of anything you want. Joyce, you want to go first? You want me to?
Go ahead. I'm not going to do an overview unless there's questions, but I did prepare something that's already listed on the agenda.
Sure. Oh, I'll give a quick overview. Madam Chair, trustees, my name is Rich with Emeritus. I'll go over the years. Appreciate the opportunity to be in front of everybody today. I'll make this short and sweet since we only have 32 teeth to talk about. Roughly, you're down year over year and a total spend of roughly 2.5%. Total claims paid over the last rolling 12 months, just over $207,000. Your PPO savings and your claim savings numbers are actually up, which is a good sign. Overall, your cost share to the member, if we look at the top line, 13%. If we look at the total spend, roughly 22%, $60,000 towards the member, and again, that $207,000 towards the trust. We did actually see a slight increase in some of our dollars spent moving towards basic and major services, not drastic. But overall, we saw less claims coming through the door and more of those going towards restorative services. Two standouts in procedures were actually some of your surgical, whether it be on the periodontal or some of the oral surgery that were above the benchmarks we'd like to see. Overall, your continued drive to drive people through the network through your plan design is working. We have 99.9% of all paid claims going through the network, so we still have room for improvement. 0.1%. So by all means, you're a standout as far as the company's spread and your benefit design and your structure and your relationships that have helped us build the network throughout the area. To give you a comparison, throughout the state, we see typically roughly 81% of the claims go through the network. So you're 19% above a general benchmark. That's a positive for you. That's positive for us, as well as down to the member level. Overall, your savings, what you see roughly off the retail spend is 33. Excuse me, it went up. Last year you saw 33.7%. This year for the rolling 12 months, 34.1%. So you're seeing a great savings thanks to your plan design, thanks to your partnership, and your members utilizing the network. That was really brief. Any questions?
Any questions, Rich?
Okay. Thank you again for the opportunity to serve the trust, for coming up today, and I promise I'll keep Dave safe on the drive home.
Thank you, Madam Chair. In answer to your question with regard to the deductibles, et cetera, the difference, there is a 2,000 calendar year deductible on the individual, a 3,000 calendar year deductible in the silver plan. Calendar year deductible family is 4,000 and 6,000 on the silver plan. Annual out-of-pocket individual is 6,000 under the gold plan, 6,850 under the gold, silver plan. And the reason why it's capped there is because that's the max you can have under law. So otherwise I'd have put it higher. But in any event, annual out-of-pocket for the family, $12,000 and $13,700. Again, that's dictated by law. The co-pays under the gold plan are $55. The co-pays under the silver plan are $100. Next difference comes in your prescription drugs. Under the gold plan, it's a $5 copay for generics, $35 copay for preferred brand, and a $65 copay for non-preferred. And the silver plan has a $25 copay for generics, $80 copay for preferred drugs, and $160 copay for non-preferred. The emergency room has a $200 per visit copay, then the plan pays 20%. Under the silver plan, it's an 80-20 program subject to deductible. So you have to make the deductible first, and then the plan pays 20%, or excuse me, the plan pays 80%, and the member pays 20%. Let's see, anything else? That's the only other difference. Any questions? Okay.
All right, any other questions from the premium rates worksheet? Okay. All right, we'll move to 2.5, issuance of request for proposal, EBT. Might be the report on this? Or is it just, I think we just were looking at dates.
Correct. The EBT, the RFP for the EBT consultant was sent to you. The items in yellow, highlighted in yellow, basically were just dates that we needed to clarify. And I think we've already, I think we can handle that on our end if you're willing to just go ahead and shoot for the January 1 as the target date of starting for the new consultant or the existing consultant, whoever that may be. January 1 would be the targeted date to begin that service. So if you're okay with that date, we can work backwards from there to figure out when you would actually publish it, send it out, and allow us enough time to review it and then bring it to the school board, the governing board, as well as you first, and then the governing board to get all of that taken care of in time for a January 1 start date. So if you're okay with that, then we'll take it from here. And there will be, we would like to have several of you, if not all of you, involved in the review process, evaluation process. I think that as many as would like to join, the better, because I think that all of you should have some buy-in on that, and then eventually it would go to you anyways to vote on. But we'll follow, we'll get down that road a little bit later. We're probably looking in the late August to early to mid-September range for that. All right?
Yeah.
Thank you.
Okay, then 3.1, EBT consultant compensation.
I just have a question, Madam Chair, on the 2.5, that does not require a vote because Mike's
Correct.
doing that. Check these off.
All right, under 3.1, EBT consultant compensation. This is placed on the agenda so that we're changing our procedure, Dave, because it was coming up the commission of the Blue Cross Blue Shield contract, which is no longer occurring. So we wanted to make sure that something was set in place through January 1. Dave, do you just want to go over details on how that would be set up?
Basically, I have currently a consulting contract that calls for 1.5% of the annual contribution to the trust, and that's still in place unless it's revoked. It's still in place. And what I've tried to do is keep it at the 1.5% every year. So with all the commissions being stripped now out of the Blue Cross contract, the reinsurance contract, and et cetera, then the existing consulting contract, in my opinion, would take precedence and become in place, and then I would just, as I get notification of contributions coming from the trust on a month-to-month basis, then I will bill the trust for 1.5% of those contributions, and it will show up in a line item in Mike's report.
And that would be done on a monthly basis.
Done on a monthly basis.
Okay. Any other questions, members of the board? Okay.
Actually, I do have a question, Madam Chair. Regarding the agreement that we have with Dave, because we're I guess basically going to make a decision in January for a new agreement, so Dave is under the guise of the new agreement effective January 1. Is there anything that we need to do as a board regarding Dave's current agreement so that those dates match up? Or, you know what I'm saying?
I think there's simply a notification process. I think that I'd be very comfortable with like giving the other party at least a 30-day written advance notice of its intent to do so. So a 30-day advance notice would be sufficient. So if you select your consultants for next year, and it doesn't have to be myself, then for December 1, you should send a termination letter to Dave Stewart and insurance professionals.
Well, if it is you, then you're going to have two.
Either way, in January,
It's a new.
we would be writing a new contract
Right.
based on fees and what's selected within the RFP, so then,
So
I
this
think it-
agreement.
so I'm sure we'll give 30 days written notice regardless, because a new contract will be issued January 1st. Any other questions? All right, 3.2, telemedicine. Marcia?
Madam Chair, this is an item that I wanted to just discuss and possibly suggest that we do a little more get a little more information, research, and Dave can help us with that. And I've got contacts that I can forward to Dave as far as communications and some of the information. In prior meetings, I had handed out a clinical trial study that was done that I was able to obtain from an NIH, National Institute of Health study, that compared, this particular study was on treating obesity via telemedicine, and so the core group was you go to the doctor once a month, every 3 months, and then you're given a diet, and it's just pretty much self-reported kind of information. The other trial group was the same provider visit once a month for 3 months, but in addition to that, there were weekly telemedicine visits with a nutritionist, a health coach, that kind of thing. And the difference in the outcomes of those two core groups was significant, to the point of, in a period of, I think it was 16 weeks, the core group lost about 2% of their body weight, total body weight, and the group that was being monitored by telemedicine, the virtual health coaching, was over 7.5% of their total body weight. So there was a significant change in their labs and a lot of different various things. And my suggestion, at least to explore the opportunity to entertain the idea of doing a telemedicine coaching situation for some of the diseases, and specifically obesity is also related to the diabetes, high cholesterol, hypertension, and all of those types of comorbidity factors seem to be connected and also be effective for the same treatment. So I would like to recommend to our trust that we have Dave look into some information, and I can work with them on that, on putting some kind of a presentation together on the viability of that, and if that's something that can be offered through Cerner, or if it's something that we would have to look at through another vendor of some kind.
Christy, you might come out to talk.
Sorry, with the new rules. So Cerner, through the Wellness Dashboard, the portal that you, as part of your service with Cerner, we do have a talk to a dietitian, talk to a trainer. So members can talk to a nutritionist or a trainer at any time. They do send an initial email, and then they set up a talk from there, or they can correspond through email. A dietitian will send them meal plans, things like that. That is included in the service. And so as we push the wellness portal, which I believe is one of Mike's goals too, there is that service, so it's already included in your fee to Cerner. Also at the center, I mean, we do a ton of coaching. We do a lot of diet, a lot of exercise. I mean, I have probably about 12 people right now that are coming monthly with me doing that, and then Laura has her own batch of people as well. But just food for thought. You do already have those services, and we can really advertise those more, push them out to members more, whatever we can do on our end to make sure they know that service is available to them. It would be interesting to see some of the other data too, but if it's already included, in your service, it's just making sure members are aware that it's there and they can use it.
So to be clear, what you're saying is that the member has an opportunity to do some kind of a face-to-face visit?
With me or Laura now online through the portal.
Through a virtual
Cerner is working on some telemedicine stuff in the works, not official yet, so not out there, but the talk to a dietitian and nutritionist right now is more through phone or email, not telemedicine per se. I mean, hopefully in the future we'll be able to advance on that, but right now it is through email or phone.
Well, and I think the reason why I think it holds merit is that there has been about 10 years worth of data now in other countries, because we're not as further along in this as some of the other ones, but there has been a significant change in the outcomes with having that face-to-face visit virtually versus the phone and the email. And I would like to see Cerner at least explore. You're saying it's in the works, and I think most of the organizations are looking at something like that, but to target specifically those diseases, because again, everything that I've seen over the last several years, we still have that same group of diseases that we're managing, that we're trying to address, and we don't seem to have a lot of leeway on, or a lot of progress on that. So it would just be something that again, I'd like to see, what Cerner would have, and then maybe if there, because there are other organizations, there are other telemedicine groups that could, present to us, so we can at least get some ideas. But I do think that it's part of the future, and I would like to just kind of get a jump on it.
I won't take up too much time. I just want to say this is a very effective tool as someone who's lost 170 pounds in over 2 years. Telemedicine is something I utilize very often with nutrition and asking questions and things like that. And this is a tool that I get through my EBT-based insurance. And it's something that I can log on 24/7. I get that face-to-face care. I get the emails, the text messages. It's something that I don't have to go to an office, or it can work around my very inflexible schedule sometimes. So it's something that's a fantastic tool for me, that when I don't have a flexible schedule, I can still get that wellness that I desperately need in.
And one of the nice things about those virtual visits, in my experience, and the companies that I've worked with, is that some of the patients, they're actually seeing their health coach or their nutritionist on the weekends or 7:30 at night. And so it doesn't, although it's nice to have it in that regular workday schedule, like Steph was saying, if you have an inflexible schedule, sometimes it would be nice to be able to have those, and if there's someone available to do that. So again, I think it merits exploration.
I remember, gosh, Chrissy, it's been a few months ago, but I read an article. I get all kinds of articles from various organizations on health. And I read an article that Cerner had entered into an agreement with a Teladoc kind of organization. And so I emailed the home office.
It is in the works. We
And
do
said,
have some telemedicine.
okay, this is great. When?
Like
And they said,
American Well or Teladoc.
Yeah.
Yeah.
It's still
I think it was
in the
more
works.
American Well.
That's the company that I work
Teladoc.
with, and they do a good job.
American Well and Teladoc are probably the two best out there. And so I know that they want to do that, but they obviously have to get all the contracts in place and how they're going to do it. And I know Teladoc is aggressively moving forward. I just read an article yesterday that they now have partnered up with a group of specialists that employees can now call and talk to 24/7. So I know Teladoc is aggressively pursuing and growing their list of providers, but I think American Well is also doing that as quick as they can. I think they have, for example, a contract with, I'm just going to forget it, Cleveland Clinic. And Cleveland Clinic is one of the best clinics in the United States, and so I think they have the agreement with Cleveland Clinic to help respond to their patients or their members as well. So I'm anxiously awaiting to hear the announcement that it's ready to go.
I do know it's in the works planning phase. Hopefully in September, when we do our annual and some of the Cerner group is out here, we'll have, I'll put it on their agenda to tell us what they can so far, what's going on. But I do know we do have some telemed that will bring. Another thing we got to think about too on the medical side is privacy and what visits are appropriate on telemed and not appropriate.
Well, they're all, they have, American Well, for example, obviously, well, not obviously, but they have a HIPAA compliant connection and whatnot. And I actually was at a telemedicine conference last week, and American Well was mentioned because they now have an agreement with every major insurance carrier. And I think they're one of the few, I don't know if Teladoc is there yet, but I know American Well actually has the nutritionists and the coaches, as well as the MDs. And that's not, we're not necessarily looking for the MD nurse practitioner because that's in place, but it's the nutritionists and the coaches and the registered dietitians and things like that. So.
And then, Marcia, maybe you can answer, or Dave, expand upon this. What does it look like as far as a billing scenario to the EBT? If something like this is built in, if it's not offered through Cerner?
Teladoc, in the quotes that I've seen coming from them, it's roughly $250, and I suspect that they keep broadening it and adding mental health and all the rest of this stuff along with it. It's going to be pushing $350 per employee per month, but that will be per employee, not per member. It'll be per employee per month. Joyce, what's Gilsbar's experience with Teladoc?
We can pay based off of an invoice,
Right.
like Dave was saying, and I also have some groups that base it off of their plan, a copay visit. So the plan would pay like a normal office visit, and then the member would pay whatever the plan's copay is.
Well, and something that we should
Or less.
consider too is that in the telemedicine laws and parity laws, Arizona is one of the most aggressive. Arizona, Nevada, and California actually. Nevada, I think, has the strongest parity laws, meaning that a plan, and obviously this is a fully insured plan, but we would look at those as comparison, but there's a parity that says whatever we would pay, as a provider visit in office, we would have to pay the same amount in a televisit. Some states pay less, some are the same. But the other part of it is that all of the types of services, so those CPT codes, kind of the preventive visits, those are all recognized for telemedicine visits, just like a level 2 or level 3 doctor visit would be. So all of the codes are recognized, and they have certain modifiers that you would add to that, and those can be figured out. But the point of it is that we've come so far now with telemedicine that these companies are recognizing and they're implementing these types of programs in their insurance plans. So, we're not, first year out. This has been several years coming. And this is the first year that I've seen it this strong, that they're actually giving us list of codes, giving us list of, services that can be provided by telemedicine, and then requiring, so for example, it's called an asynchronous connection. So that face-to-face visit is one type of service, but they may not necessarily pay for a phone call or an internet or an email or something like that. So there's been a lot of progress made on it, I think.
We have clients that go both ways as well.
Yeah.
Do you see any restrictions on number of visits or how it's used?
No restrictions or limited visits. They pretty much 24/7 can use the plan all year long.
I do have it in
And the
Parker,
convenience is
Arizona.
nice.
Okay.
And they decided to pay per employee per month so that the employee would not have to pay a copay for the visit. And so there was the two options. It was like 50 cents for just the access, and then the member would pay a copay for the office visit. But they decided to go with the $250 per employee per month so that the employee would not have to pay a copay. They love it. And I'm anxiously awaiting to see how it, settles in, and I get the data reports to see if I've reduced the number of office visits as a result of it, but so far, it's been well received and well accepted.
Yeah. I mean,
And that's pure telemedicine.
Right.
It's far more than weight reduction. I mean,
Right.
you got a specific approach here, weight reduction, and I think that's fantastic. I think the more touches you can make with the employee, either face-to-face or by the telephone, that employee gets it in their mind, or that individual gets it in their mind that somebody's watching, and that I need to really focus in on achieving my goals. Telemedicine would go a lot further than just the weight loss.
Right.
So,
and that's why I was just to start with that. But it is, you're right, it's growing quite a bit.
Is there any participation data as far as
yes.
per employee per month? If it's a 10% usage, doesn't make a lot of sense, but if it's
You're right.
So,
And that's what I'm thinking. Mark's sitting over here by saying on the EAP services, we had 10% utilization while we're spending $12,000 a year.
Right.
That's what I'm looking for on these other reports after 1 year, to see if only 10% of the people use it. But I guarantee you the people that do use it, they love it.
They love it, yeah.
There's actually a school district in Nevada that I met with their medical director last week or 2 weeks ago, that said he would be happy to share some information on their outcomes. But there's a sort of a dual thing. They're actually doing telemedicine for students so that the parents don't have to miss work, but they're also offering it for their employees. And the point of it is that the more data that we can look at, the better. This was specifically just to discuss, as sort of a stepping off point, And what we're finding with the telemedicine, especially for obesity treatment and those comorbid risk factors, is there's a sense of, when we had patients in our clinic come in, there was always that anxious time where if you knew you had a really fun weekend and you didn't want to get on the scale kind of thing because your guilt factor, that could be a problem. But these visits are connected, and the scales are home. They're all Bluetooth enabled, so there's no. I mean, you don't have to worry about the fact that your rate went up or down because it's already been noted in your file. So there's a lot to that part, but I think it's just the fact that there's that connection and there's that interaction on a weekly basis. And we know that the U.S. Preventive Service Task Force says that 12 to 26 visits a week or a month, 12 to 26 visits per year is extremely effective for weight loss programs and has a longer outcome, meaning that the patients don't regain their weight or they continue to have improved health factors. So,
To be further discussed.
and I can work with Dave on putting something together if you
Absolutely.
want.
I think it's a great thought.
All right, 3.2, trust accounting services. Can I find it?
I'll send these down for you. If you recall,
I printed mine too.
If you recall, we only contracted with the firm until July 1. And so Carrie suggested that I put this on the agenda for your consideration to now renew or re-engage, if you will, the CPA firm for the entire year of 2017, school year, plan year for 2017-18. And Mike has sent over a proposal to do that with a modest increase from $250 to $300. I would make a recommendation that you consider doing that.
And Mr. Murray, you would be in favor of us continuing
Yes,
on this
I
path?
think so. Are you going to share this?
Well, I
Mr.
didn't see it was on the agenda, but I said we will.
Is it appropriate to combine the financial statement with this agenda item?
Yeah.
Make it all the
Sure.
same?
Yes.
Okay. Because I believe that what he's put together, and I know he's been working diligently to try to get all the information to put together a year's worth of information in one document. I think with the progress that's been made in getting us to this point, it would be nice to have these services to continue for the school year, to allow this to firmly kind of get rooted into place before making other decisions beyond that. So I'm in favor of it.
Question I had is, so Mike, you would be doing this on a monthly basis?
Yes.
And then the board, we don't meet monthly, we've been meeting more frequent, but probably, taking all likelihood down the road, we'll probably be looking at, from what I understand, maybe quarterly meetings. Would it make, and then, I know this was the one that you sent is a year-end compilation, so on a monthly basis, we'd be getting something for the month and then a year-to-date?
Yes.
Okay. That would be my only question is if we don't meet on a monthly basis, is it necessary to have these reports monthly as opposed to possibly quarterly?
From my standpoint, I believe that it is better to do it on a monthly basis, even if the board is not meeting to review and take action on. The report would go to Mr. Murray on a monthly basis, can still be distributed to the board on a monthly basis, even if you're not meeting.
Sure.
From a processing standpoint, a preparation standpoint, it's, and Mark is shaking his head, it's
the same level of effort.
Yeah.
Exactly. And the proposal you have in front of you actually is an engagement letter. The fee wouldn't change whether it was monthly or quarterly, quite frankly.
Okay.
I'd make a motion to accept the engagement letter for the fiscal year 2018.
Second.
Any further discussion? Mary?
John?
Oh,
I just
sorry,
wanted to
John.
know what we're spending.
I didn't hear.
What are we spending?
$300 a month.
Marcia Cox,
Yes.
Mark Nixon,
Yes.
Pat Rooney.
Yes.
Hal Christensen.
Yes.
Carrie Thompson.
Yes.
Madam Chair,
Yes.
as Mr. Lurie asked, I think it was appropriate to go over the financials that were presented also. I didn't see it emphasized, so. First, let me thank you for your confidence in our capabilities. I appreciate the confidence and look forward to providing the services in the next fiscal year. I emailed Ms. Lurie, I believe you shared with me, the financial statements, the compiled financial statements through May 31. Some of these numbers will probably change when and if, when the final audit report is issued. I also was in communications with Melanie, actually just last week, and she indicated to me that the audit was in their final review process. So they've done all the number crunching, put everything together. It just needed, for quality control purposes, need to go through their review. And Melanie is out of the office for a while, so I asked for an update Monday. Got the same email on a reply that she was out of the office. I will briefly go over the numbers, and I know there was one question from one of the board members after reviewing it, and I will address that. Statement of net assets basically is your balance sheet. What may change here as a result of the audit is the total equity and the unrestricted net assets. That number probably is going to be significantly less as a result of the audit. Since I don't know what that number is, I can't make the proper adjustment. Also, the audit is prepared on a GAAP basis, generally accepted accounting principles. These are prepared on the modified cash basis. Probably what they're including is some accounts payable that existed at the end of at 6/30/16 that I have not recognized here, which would affect the net income in 2016 as well as the statement of net assets. So when those numbers finally become available, I'll make the necessary adjustment, hopefully on the June financial statement for you. And just while I'm still on the net assets, Mr. Murray reported what the Morgan Stanley balances were as of May 31. You'll notice they're going to be somewhat different than what's on this report, and that's due to outstanding checks that have been issued that have cleared the Morgan Stanley account as of May 31. So you're always going to see a difference in those balances. And part of the issue in the audit was reconciling a lot of outstanding checks that have been issued. Some, and even when we went through the reconciliation process, and we went back to July of 2016 forward and reconciled every single one of those statements going forward. There are a number of old outstanding items, and at some time between now and hopefully the end of June, I'd like to get together with Mike and Kelly to review some of those and find out why they're still outstanding and make decisions on clearing those items so there's a better balance going forward. On the statement of activities, basically it's your P&L for those of us in the for-profit business, and lists various items of revenue and the expenses of the trust, and you can see for yourself what those are. On the draft that I had issued, there was a question, Dave raised a question on patronage rebates. So I got information and made them, and thank you for sending that information. I took the liberty of breaking down those rebates into the various categories, and you can see on there's patronage dividends, a true-up, a claims audit, and then the regular rebates. So a total year-to-date through May was $83,000. We will continue this reporting as long as we get that information of what that breakdown is when those rebate checks come in. There was a question raised on, can we, on the financial statements and the line item, indicate who the vendor was, and specifically how much was paid to a specific law firm. Normally in financial statements, especially compilations or even any kind of financial statements, The vendor name is not identified in the financial statements. If you would like, and again, I can't stress enough, these are your financial statements. You tell me the format that you want. I would object strenuously if you wanted any particular vendor's name anywhere on the financial statements, quite frankly. One way to answer the question that was raised, and it was regarding professional fees, is to break down those professional fees by category. As an example, legal fees, accounting fees, and what other professional fees that you may have, and break them down by those categories. Then you know what the total in legal fees are for a particular period and year to date. You know who you're paying legal fees to, so you can identify it, and the name of the firm is not identified on the financial statements. That's what I would suggest. There will be some minor changes going forward. Net income will be changed to excess revenues over expenses to be compliant with the nonprofit world. And I think that's about it, unless you have any other questions. Certainly be more than happy to answer any questions that you might have at this time.
So Mike, so you are going to break out those professional fees, or is that something we would have to direct you?
If you tell me today you want them broken out into various categories, I'll do so. It will start with June, and it will have the year-to-date numbers broken out by category. You just need to tell me what categories you want. Looking at the report, I see legal fees. There was some actuarial fees that were paid that are in that category as well, and it would appear to me the consulting fee. So if you tell me that you want those broken down, I'll make that necessary change on the June financial and make sure that everything that is in there right now as of May 31 is reclassified into those various categories.
So could we send Mike maybe a list of suggested categories, and then
I think those are the ones. Is there any
is third
other?
party,
Yeah.
are the
I mean,
third party administrator professional fees, or
I'm sorry, say it again.
is a third party administrator considered a professional fee? Because
It's not a consulting fee. There is an expense consulting fees, I believe. Or management fee, I'm sorry, management fee. That's all paid to one company. That's all that's in that one right now.
So to be able to get the additional detail, the drill down, so to speak, that would be something that we would do with Mike Murray.
Yes. To get specifics, yes. I can break them down into general category within that classification of expense for you.
Right.
But to drill down to see who it was paid to, you have to.
Right.
But we can see,
That
Mike
makes
sends
sense.
that to us now through Mary because it's on the Morgan Stanley if you go to the end of the report.
Good question.
Yeah, I think it would be a good idea to have the categories. I'd like to see that.
If you could ask Mr. Murray to send me a list of those categories you would like to see with subcategories within the main category, and then I can make the appropriate adjustment going forward.
So other than, Mike, other than, say, legal, accounting, consulting, and management fees?
That's probably it.
That's, and then the rest of it would just be miscellaneous if there was anything that didn't fit in one of those four categories?
That is correct.
Okay.
What does, let's take Gilsbar, for instance. Where does Gilsbar fit? 'Cause
Right
I'm sure the
now,
management fee is
right
Cerner.
now it's in management fee.
So what's Cerner under?
Consulting fees. Oh, wait a minute, I'm sorry.
No, it shouldn't be.
It's the other way around.
Yeah, okay.
It's the other way around.
Okay, that's, all right.
Cerner is under management fee.
And
Gilsbar
Gilsbar
is
under
under
consulting.
That is correct. But included in that professional are other professional fees, for example, attorney's fees. So you're asking me to break that down and be specific within a subcategory. professional fees. I don't want to say professional fees. What is Gil's Bar fee? Give me.
It's a service agreement,
The
so
service
it's not
agreement.
consulting.
Benefit management.
Benefit management, thank you. And then you'll see professional fees, benefit management, professional fees, attorney, professional fees, accounting. That's probably all you need, right? Those three.
We have American Health Group, which would be, that's a review of large claims, so that would probably fall in the same category with Gills Bar, I would
It's a-
think.
Yeah, same kind.
And there was the actuarial, United Healthcare was the other one that I saw. And we can break all of those out and like Hal said, anything that doesn't fall in those categories is just like this thing, which would be minimal.
So we could do that right now rather than go through Mike?
Yeah, well, if I'm getting a consensus from the board,
Yeah.
that's what you want, yes.
Yeah, let's just do that.
Okay.
How can you say it so I can put it when it is?
Yeah, we're asking GDK to provide a breakdown of professional fees. And they will break that down into probably 4 specific categories. Do you need the categories or? Well, you've got legal, accounting, consulting, and then management. Management, and you mentioned that's the benefit management. So I think, and the bulk of, from what I'm hearing, the bulk of consulting and management, one's going to be Gills Bar and one's going to be Cerner. And I think that's what we were trying to do, is break it out. So those 4 categories I think would cover it. And then miscellaneous would be whatever's left. Like all the big salaries that we make here as the board members.
No, let's not take it.
Now, I would separate that out.
Your question.
Do we need, we're good?
What Hal said was right, we're good.
We're good.
Everything I say is right until my wife tells me it's not.
Right.
Good.
All right, thank you.
Thank you.
Mike.
Thank you, Mike.
All right, we will move to 3.3, final approval of employee paid voluntary life. Dave?
Yes, as you recall, at the last meeting, Guardian had submitted voluntary life rates that were a little higher than what our current program was. And so you asked me to go back and see if I could get them to match the rates. And I get an initial response saying that they were going to match the rates, and even on their renewal proposal they sent me, they had a note in there that the voluntary life age band of under 25, they had dropped the rate down to 7 cents as opposed to the under 30 rate of 60 cents or 80 cents. And so I sent a follow-up email to that saying, okay, I need to know if you're matching all the voluntary life rates for this plan. I have not gotten an answer back. I think our rep is on vacation, but I have not gotten an answer back, so I may have to table that for now. And we did have to move the effective date of the life insurance back to 9/1 because there was no way to get all the enrollment materials and et cetera into the plan for the leaving or exiting employees prior to the close of open enrollment. So in conversations with the district, we decided to push the effective date back to 9/1, which will allow people to have the opportunity to review the proposal and what their rates are going to be. Because one of the things on the voluntary plan for short-term disability is that it dropped down to an 8-day waiting period as opposed to a 21-day waiting period, and those rates are going to be significantly higher. So we wanted to make sure they had ample time to consider that, and the district agreed to move the effective date back to 9/1. So we do have a little time to make sure we can true up these voluntary rates. The fact that they did reduce the under 24 down to 7 cents is a good sign, but I still don't have confirmation that they're going to match all the other rates because they're still a little high on the voluntary side.
So we will need to readdress at the August meeting.
And so does that decision by Guardian have any effect on what we voted on? Because when we voted on all these things, we were saying that it was going to be effective July 1. And now we're changing the effective date on some of the benefits to September. Is that what I'm hearing?
Did we put an effective date of the plan, or were we saying we were going to approve it starting that fiscal year?
I don't know if the minutes reflected the actual target.
Okay, so from the minutes, as written, Mr. Nexa made a motion to accept Guardian based on the 8-day waiting period and assuming the company will match UNUM's rates for voluntary life insurance. If Guardian chooses not to accept, the group will accept the proposal as is. So we actually didn't have a date in that motion, so I think we're okay.
So then going forward, do we need to have an effective date that we need to vote on today that's a 9-month effective date, or is it just open-ended? Because my question has to do with, if we're going to change the effective date this year to 9-month for this plan, is that going to be the effective date going forward?
No.
Okay, so it's going to be a short year?
Yes.
Okay, and so the
That's my recommendation.
say it again?
That's my recommendation, that we go
Prorated.
next year. It's a
So-
short year.
Okay, so, and then, so the premiums and all that, so basically everything stays in place until there's a change?
July of 19 or 18, July of 18.
Okay. So then we would have to agree that we're going to recommend a short rated, or prorated year?
And you can do that on August 2nd, the next question.
Yeah.
You say August 2nd? I'm sorry, I'm not completely reading now. So
Yes, August, I would suggest we do that August 2nd, because we would know exactly what the rates are, and then how they would prorate at our August meeting.
Or we can always have a conference call in the conference room and open it up to anybody who wants to listen. Do that as well.
You don't see any issue with timeline as far as approving August 2nd to be ready September 1st?
Well, yeah, I do, I potentially do, and that's all the packets. But on the other hand, if they agree, and I know it's going to happen, then I can order the packets.
So are you waiting for something from Guardian?
Yes.
Guaranteeing that they're going to
Yes.
back the rates?
Yes.
Okay. So can we make a motion to table this decision until next?
Well, there's no motion, so, but yeah, it'll be back on the agenda, yes.
So we can move to table it?
Yes. I just have one question for Mr. Murray. Do you see the 9/1 effective date okay as far as you guys rolling it out for employees?
If I remember right, that was already mentioned as a possibility in the last meeting, that we would have there would be a gap. So from what I've been talking to Sherry about, I don't think there's going to be an issue. I think the issue is making sure we have all of the plan documents sooner than later so that we can make that transition. But I believe September 1st was already thrown out. as a possibility the last meeting, if I'm correct. Because there was concern that this wouldn't happen by the July 1.
By July 1.
I don't see anything in the, are you talking about the meeting, the minutes from the last meeting?
No, not the minutes, but I think there was a conversation about, there was a concern that this wouldn't happen by July 1, and there would be a possibility of having a delay in starting this new.
Well, and the fact that employees are not
Yeah.
at work, so
Yeah.
it makes it a lot easier to roll in new benefits when we're back in session anyway. So I think September 1st makes sense. All right, so we can table 3.3 for the August meeting. All right, 3.4, report on committee in conjunction with school board to review trust document and develop policies. I know that Hal, Marcia, and I were involved with the subcommittee work in reviewing the trust document and revision and rewriting a lot in some cases. So those revisions have been made and changes, and I believe, because I just got an email yesterday, that we're pretty much on the revision of the exhibits also, A and B.
The only thing we were waiting for was the information on the vision, or the life and AD&D vendor.
Okay,
And so now we can't do that, but we can list it without a vendor name.
Okay. And those, or process-wise, are going to be reviewed on both sides by the school district's lawyer and by ours. So I plan on having that sent out if we we need a motion here to have that reviewed, or can we just send it under our contract with legal services?
I just thought that was our process. We discussed that Mike was going to be sending it out to the attorney. And you're saying the attorneys on both, attorneys
On
for the
both
trust
sides.
and for the school district?
Mhm.
Okay. Do you think you need a motion to that?
Anytime you spend school or district or trust funds, you would need a motion to do so.
They don't do it for nothing?
I'm sorry, I tried.
We're a struggling school district. Okay, then I'd make a motion to proceed with the revised trust document to go to review by attorneys for the trust and for the school district.
Second.
Any further discussion? Mary?
Mark Nixon,
Yes.
Hal Christensen,
Yes.
Pat Rooney.
Yes.
Marcia Cox,
Yes.
Carrie Thompson.
Yes. All right, 3.5, review and approve medical specific and aggregate stop-loss rates for 17-18.
Madam Chair, members of the board, this is the rate sheet that we had last time that was not on the agenda so that you couldn't approve it, but I did. Some good things have happened, and that is that they were asking for a rate increase on the aggregate attachment points, but based on the paid claims history through May, they have agreed to keep the aggregate attachment points at the same rates as current. So overall, which is almost unheard of, you've actually got a 1.6% decrease over the prior year if you stay with American Fidelity and the 130,000. if you want to assume a little more risk and go to 150,000, you still don't save much. So I'm not sure if there's a risk because your aggregate factors goes up when you do that. And then if you wanted to throw the 130 back and then put a $50 aggregating specific on that, then that would produce a 2.73% reduction. And if you wanted to do 150 spec with another 30,000 aggregating spec, you still only get a 1.50% reduction. So my recommendation is based on the decrease of 1.64% that you agree to use American Fidelity Assurance Company for the 2017-18 school year.
Or based on the level of risk that you take on this $50,000, I would agree and make a motion that we accept the renewal option on American Fidelity.
Is that seconded?
I'll second.
Further discussion? Mary?
Okay. Pat Rooney?
Yes.
Marcia Cox?
Yes.
Hal Christensen?
Yes.
Mark Nixon?
Yes.
Carrie Thompson?
Yes.
So Carrie, I have the document for you to sign
sign
before you
today.
leave today, please.
Okay, 3.6, discuss offering an HSA plan through the trust. Dave?
Well, I think at one of the prior meetings, and I don't remember that I was here, I think it was in your April meeting, I was not in attendance, but the question surfaced with regard to using HSAs as an option for the employees. And so I went out, reached out to some rule-making organizations and federal government and et cetera, which you can certainly have a dual option. You can have a plan you can have the silver plan, you can have the gold plan, and you can have an HSA plan. I just want to remind everybody, if you do have an HSA plan, then it kind of throws a kibosh or a monkey wrench into your medical center, because then the medical center would have to charge a copay each time you went in, equivalent to what you would pay on the outside, which currently is $55. So if you wanted to offer the HSA and an employee enrolled in the HSA, then if they went to the Center for Services, they would have to pay $55. That's the law.
They couldn't have a separate copay, a different amount?
No. Well, they could have a different copay, but it'd have to be equal to what you're presently paying on the outside.
Can I add a little bit to that?
Yes.
On a high deductible health plan, you need to meet the full deductible first
Yes,
before.
that's true too.
So you'd have to meet the deductible first, then the plan could start paying. So the member, if they went to the center, they'd have to pay the full cost.
Yeah, you're
Of
right.
an office
I
visit.
wasn't thinking of the deductible piece of it. I was just thinking of the copay plan,
Right.
which is bad enough. But yes, you're absolutely correct. The member would have to satisfy the deductible, whatever that was, first, and then it could revert to the copays.
Well, I know that question was brought up in a call to the public, I think, and I don't know if the person that brought it up is here.
No.
Can you do it? Sure, you can do it, but then that member would probably not be willing to use the Center for Services, because not only in the center, but in any other doctor in town, they would have to satisfy the deductible first, and then it would revert to that copay, which is roughly the $55. But in answer to your question, Marcia, yes, you could have a copay lower, but the feds are going to look at it and say, okay, why do you have a $55 copay for your out-of-center cost, but you're only charging them $30 in the center. That would not fly. You get written up for that.
Are there any restrictions on when an HSA can be put in place according with what the deductible needs to be and things? Or would it mirror the current packages we have?
Well, usually, if you're going to offer an option of putting in an HSA, you want to do it at the same time you renew everything else. So
Well,
it'd be
right.
July 1 to June 30.
But I'm saying as far as what we set the deductibles at, are there laws as to what that needs to be?
Most today, the deductibles for HSA programs, the ones I'm selling on small group and individual, are in the $4,000 to $5,000 per person range. Otherwise, they can't afford a premium. So that's what I'm selling out there in the small group and in the individual plans, is $4,000 to $5,000 deductible, which means it's 2 times the family. And then their out-of-pocket max. We even have some carriers offering a deductible that is at the out-of-pocket max, and then you have 100% thereafter. So you meet the deductible is $66.50, and then you're 100%.
And as far as premiums on those types of plans, what do you see? Where do you see premiums like?
Premiums are generally about 30 to 40% less.
But it wouldn't benefit the employee.
Correct. It would basically, I'm looking at probably family coverage if someone's maybe looking at, or someone who flexes or likes to flex and wants an account that rolls over.
Yeah,
Is
see,
maybe
you're
the benefit.
right. The
You know,
dependent cost would be less as well. But yes, it wouldn't impact the employee because the district would continue to pay that. But the employee would pay less with their dependent contributions. But if they wanted money in their HSA account, they would have to put that money in their HSA account. Today, in 2017, it's $3,350 on an individual and $6,700 on a family. But that's going to go up next year in 2018. The proposal is that that be whatever the out-of-pocket max is. And so that could be $66.50 on an individual and $13.7 on a family in 2018, if it gets passed. I haven't seen it pass yet, but that's what they're proposing.
and if the premium, let's say an employee, let's take Mark's example, is 30 to 40% less, do you see it typical that the difference then is put into the HSA account by the employer, or
It's all over the board. It's all over the board. I've had a CPA firm that did that. They put the money on an HSA account for the member, and then I'd have others that say, no way.
Yeah.
Or I'm saving $150, I'll put 100 in. Or I'm saving $150, I'll put 50 in, just to get it started.
Right.
But typically, isn't there some kind of a contribution from the employer?
To the HSA? No.
Not as common anymore. I think that was common at the beginning and uncommon now.
So what I'm hearing is just, it's not feasible, right?
Well, I just don't think there's a whole lot of employee benefit.
Right.
I think once an employee understood it, they probably go, why would I do that?
Right.
And with a high percentage of coverage that's just employees, I think we're about, what are we, about 20% dependents and 80% employees, roughly? We have those numbers, I think.
Our good pals from Gilmore tell us that.
I was thinking that would be reflected in the minutes of this meeting to address the employee from Call to the Public back in April, and that it was looked into, and it's just not.
I think that's a great
It's just
idea.
not feasible. So it addresses the call to the public that we had. I think that's important.
Well, I think part of the reason why the comment was made was, again, like you were saying, where on the flexible spending account, it's a use it or lose it. With the HSA, it's a roll, you know, you can roll it into, and there's some tax advantages at retirement kind of thing, and that may be the reason, not knowing all of the background. And, you know, maybe there's an opportunity to do an HSA versus FSA kind of a half-page thing we could give, you know, publish on the website. It would be nice to have that.
Be easy to do, yeah.
So is that something that you could do, Dave?
Yeah.
Okay.
I think that was her point. She was trying to see if there was an alternative to the SFA or the FSA.
Okay.
So that, because I remember her making the comment that she went out and purchased a bunch of first aid supplies to kind of use up whatever she put in there for that year so she don't lose that amount. So my question would be, is there anything that's like an FSA or FSA and to the point where you don't lose that contribution, where you don't have to worry about using it all up or you lose it, or it would roll over? Is there anything? Okay, so it's either
the HSA
or the FSA. That's
and that rolls, and the FSA, which doesn't.
Okay. So I think that was what they were looking for.
That's
I had a
what I
few
was
other employees ask about that as well. Is there something that's like the FSA where we would contribute X amount of dollars to each year, but where we wouldn't lose it at the end of the year, where it would still roll over? So it's either HSA or FSA, and that's it. That's it.
And just a question, like, what would an HRA be under?
An
Is that
HR
an employer funded or?
An HRA is kind of a hybrid,
Okay.
but
Because
it's
like
still
we
not
have
an
an
HSA,
HRA
it's
on our
an
plan.
HRA.
And what's an HRA?
Health reimbursement account. The
And that one
employer,
rolls
it's a
over.
promise to pay by the employer for any expenses you incur up to X. It's a promise to pay. It's a great initial self-funded program for a small employer. That's what it is. Because it's a promise to pay. I've got a $5,000 deductible, I got a $10,000 deductible plan out there if you can buy those anymore, but you can't. But let's say we use the max deductible of $6,650. I have a $6,650 deductible. I tell you what, I'll pay the first $4,000 under the HRA, you pay the rest. That's a promise to pay. That's an HRA. So on this latest utilization and participation report, the question was employee versus dependent. We have 496 employees, and we have, what did I write down? 308 belly buttons in the dependent side.
Oh, well,
A little different than 820.
Yeah.
well, but if
Yeah.
you're covering a family plan, know that you've got several belly buttons on one premium.
Well, it
So
lists.
as far as percentage of employees, it
Right.
could be a little different, but
And that's under the utilization report. So, I don't know,
I think the biggest difference would be to maybe make everyone aware of the fact that the deductibles and the copays and, you know, that those would need to be satisfied in order to use the wellness center, and that there is a difference between the FSA, HSA rules.
yeah, and I think especially the centerpiece, because I think
Right.
they're thinking, oh, it'd be perfect because I've got free access
Right.
to a center, which would no longer be free. And, you know, they're looking at combining both of those benefits instead of
That's
it
a
being
good
one or
question.
the other.
it is a good question.
Yeah.
No doubt about it. I get it asked all the time. But, you know, it's also interesting. If I'm presenting an individual plan, or if I'm presenting an HSA plan to an individual, or if I'm presenting an HSA to a small group plan, and I'm talking to a male, I can do that. If I'm talking to a female, no way. It ain't happening. I want a copay. It's just a mindset between females and males. At least every experience I've had with that.
Well, it could be that the females are taking the kids to the doctor.
Exactly. The females are taking the kids to the doctor. They want to know exactly what they have to pay when they go in for that child's visit. And you're absolutely correct. I'm just explaining, the male says, I can do that. And I had the same with my oldest son when I put him under an HSA. His wife chopped my head off. So I had to explain to her what was going on. Oh, okay, I can work with that.
All right, okay, and 3.6. All right, 3.7. Trustees ask for definition of ministerial as mentioned in the RFP for consulting services. So, maybe that's Mike's.
Well, I think that
I
was,
don't know. What?
that was in the, I believe, the boilerplate document that we received from before.
Well, maybe Marcia's going to address
I think it was mine.
Okay, that would be yours.
I know Nicole had a question about that too,
Right.
from the floor, but yeah, just pretty plain and simple, it's acting as an agent. That was easy.
That was easy.
There we go. Acting as an agent.
I'll be happy to hear your confession, Mark.
What's that?
Not from a CPA, you don't want.
Yeah, you ever watched the movie The Accountant?
I thought about you when I saw that movie, Mark. No.
I'm the brother.
Right.
All right, then 3.8, RX plan revision effective date.
Yeah, when I reached out to tell National Cooperative RX of the decision to move forward, I got this email response from our advisor, Christopher Shantz, and he's saying he can't put it, they cannot put it in effect as of July 1. He's going to have to move it to a 10/1 effective date. And then he said, I'll have to prepare the documents. Well, he finally got the documents to me this week, and so if Kerry wants to sign that document, then we can shoot for a 10/1 effective date. Again, employees will be notified of the change by letter if it affects them in any way. So that's another document I need to have you sign.
Okay.
Kerry?
No.
Yeah, I don't think it changes the decision.
No.
No, because
It's
it
just a
doesn't
delay
change
because
vendor, yeah.
From an administrative perspective, they didn't want to rush it. They wanted to make sure they got it out to everybody, so they said 10/1. They do it once a quarter.
All right, 3.9, report on question from employees on whether the hospital and home health care will accept referrals signed by a nurse practitioner. And Chrissy, do you have any further information on that?
I do. Madam Chair and the board, I did do a little bit more research because I think Laura maybe tried to answer the question, but of course we wanted some founded research for you. So according to the Arizona Board of Nursing, we can, and I'm reading from them, prescribe, order, administer, and dispense therapeutic measures to include pharmacological agents and devices, non-pharmacological intervention, including but not limited to durable medical equipment, nutrition, home health care, hospice, physical therapy, and occupational therapy. Now, Medicare has their own policy, and a nurse practitioner cannot order home health under Medicare. Not many of our patients are Medicare. They're all private insurance. So private insurance, we can order home health or any diagnostic tool lab test within our scope. Hospital. Now, I will also add the hospital here in town will take all of our orders except an infusion clinic order. That is their policy, hospital policy, not a state law, not a board of nursing. That's an internal policy that HRMC has. Kingman will accept our order for everything to include infusion therapy. So I do have a couple patients that they don't want to go through a doctor they don't know or, to get an order, and they will travel to Kingman and get their osteoporosis medicine, etc. We don't do a lot of infusion therapy, but That is the only thing at the hospital here that they will not accept from us, but they will accept imaging, lab orders, medication orders, anything like that. Any questions or further clarification?
My only question, and maybe Dave could answer this, would only apply to an employee who is over 65. Our insurance would be primary, Medicare would be secondary.
Correct.
So they still should be following our policies and not Medicare, correct?
Correct. That is correct. So I guess I thought there was a question from the audience.
Yeah.
There was
They
a
could- if you could
Concerned
be your
that
PCP.
that wasn't occurring. So I guess I'm at a loss. So I guess I'm at a loss because what you're saying is that it should be occurring, but I heard that employee say it's not occurring.
So the employee, I mean, obviously when insurance, it's the employee's responsibility to contact the hospital because it was the hospital that
Didn't the
told them
hospital tell the
was
employee
holding it
that
up.
that they couldn't name you as their primary care provider because you were a nurse practitioner, and it was for a specific treatment recommendation?
Infusion clinic, probably.
I don't know, I think it was,
And I have
well, it was home
spoke
health.
with Dr.
I don't know
Rosen.
what the diagnosis was, so we didn't know that.
Okay.
So maybe
It could have
that
been
was the
infusion.
reason.
I know I've spoke with the medical director about it because, and it's also, I mean, they're profit and they're not taking orders from us. So in the medical world, you think they'd want to take orders because the hospital's for profit. But he explained to me very nicely that it's hospital policy, which they're out of Life Point in Nashville. So, you know, it comes from a different set of people that are making their policies. And he said he would bring it to their attention and see if they could revise, but as of right now, the infusion clinic would stay the same. Now, the ER does have us listed in their database. It's just up to the patient to say, my primary care is Laura Shackelford. We are in the system. I get records all the time in my name from people that go to the ER, so I'm aware that they've been there. It's just, and we remind our patients too, if they go to the ER or anything, to please let them know who their primary care. But I do know the infusion clinic will not put us down as a primary care or take the order for some of those infusions.
It seemed to me the question had to do with home health and hospice. So,
Yeah, we can't order that, so.
but that the hospital would not recognize a nurse practitioner's PCP for hospice and home health.
They just
But
may
that's-
not know all the insurance details. Because the
I
common
think they may
perception
have
when they
assumed
asked that at the
Medicare.
last meeting, and even I thought I could not order home health because I was thinking about the Medicare guideline, which 98% of people that you would order home health for are elderly and would fall under the Medicare. So I was thinking that was the rule. But when we went back to double check, it is not actually not the law. So it may have been incorrect information that they received from the hospital because that is common perception.
Well, it sounds like because it's a for-profit that they made the decision that they are not going to accept nurse practitioners as PCPs.
I think
They do accept
may
us as
have just
PCP.
assumed Medicare and
But there may be, and maybe that's worth me checking into the medical director again, if they've changed the policies. But Laura's husband was actually the director of home health for HRMC, and he took orders from NPs for home health. So I don't think that's changed, but I can look into it and make sure that there's not been a new policy put in place by the hospital as far as home health and hospice go. But the hospital doesn't have a hospice, so it would probably be home health that this person was referring to, because hospice is not at the hospital. So I can get back with the medical director and see if anything's changed, but a couple of months ago, the only thing they would not accept our order for was an infusion clinic order. And they do recognize us as PCP. We're in their database, so.
now if an employee has a question on coverage, this is where they could contact Gilsbar, correct?
Correct.
So, I mean, that would be the educational pieces that our employees need to then, if there's a question on coverage.
Right, outside of clinic.
Yes, yes.
So I think that would satisfy that question.
Yeah. All right, 3.10, review Gilsbar report on year-to-year office visits and emergency room visits.
Yes, Madam Chair, members of the board, we did put together a one-page slide, and I hope you'll have copies of this.
It's coming down.
Okay, good. Okay, so what we've prepared right here is a one-page utilization analysis on outlining the 4 major service categories, which is your office visits, inpatient hospital, routine wellness, office visits, and emergency room. Now, we looked at a 3-year spread to look at trend. We went from full year 2015, 2016, and then year-to-date 2017. And this is on an incurred basis of 12 months, so it's a calendar year, okay? The first one is going to be your office visits. If we look at 2015, we had 1,870 office visits throughout.
Outside the center.
Outside, this is all outside of the center, yes. So that was 1,870 visits. If we look at 2016, there was a decline, so that went down to 1,673. And then current year-to-date for office visits, we are at 1,309. So overall, you're looking at that downward trend in comparison to that benchmark of 3,417. So we're well below the trend on office visits. And again, we can probably attribute that to the wellness center. Yes.
Does that include specialty, anything office visit, or is this
This
just
is
primary care?
anything office visit.
So this is cardiology, oncology, any kind of specialty. Is there any way to break that down just into primary care by any chance? No.
You mean like routine care?
Yeah,
You're
like
doing just by
GYN
CPT codes?
or primary care offices?
We
like
pulled
to
this
take
just
out-
on office visit benefit type.
Oh, okay. So there's no way to see if it was a specialty clinic as opposed to like a GYN or a primary care provider?
Correct.
Okay.
We did break out routine wellness though, so that's kind of separated from there. When we look at inpatient hospital, I know this isn't part of what the wellness center does, but looking at inpatient hospital, significant decreases in utilization from 2015 to 16. We're a little bit higher now in 2017 year-to-date, but well below the benchmark, and that's inpatient hospital. Looking at routine office visits, we have a steady trend right here. 2015, 337 visits. 2016, 327. And then year-to-date, 306 for 2017. Again, well below that routine wellness office visit. Emergency room hospital, and again, this isn't urgent care services. That's something the wellness center would be able to treat. These are actual emergency room visits. Again, it looks we're on a pretty straight trend here. 98 visits in 2015. 2016, we had 101 visits. So far, 2017, we're at 79 visits. You know, keeping in mind that we still have 6 more months left in the year, so those could fluctuate. And again, well below that benchmark for these services. So again, just looking at that downward trend, we want to make it look, well, we want to attribute that towards the wellness center because that it's just a significant decrease on the office visit and routine wellness.
Only one question I had, and it's kind of the same thing as the other breakdown question. On the routine wellness, is there a way to break out pediatrics and everybody else? Because I'm assuming that's where we're seeing a lot of the regular wellness visits is under 2.
Our benefit types and subcategories are either sickness or routine.
Right.
So it's hard to break
So
out.
there's no age breakdown, or
Right.
it's a dependent or an employee?
Right.
Because that's where they're all going to be. Because I remember my
They
under
still go to
2s, you've got like 12
for
wellness
the-
visits a year when you have,
Gotcha. So
Child.
newborn babies wouldn't
Yeah.
be able to go to the oh, gotcha. Okay.
yeah.
Do they not code by age in the pediatrician office?
You know, I'm not an analyst, so I could go back and check.
The CPT code would identify the
The
age.
age, yeah.
Within a range.
A range, but because we don't see 2 and under, and we don't
Yeah.
take kids on primary until 10 or older. So between 2 and 10, they're still going for their growth charts and their immunizations at the pediatrician.
Right. So that could be a big chunk of this routine right here.
We have a question for you.
Madam
Yes.
Chair.
Yes.
I just want to make sure we're looking at apples to apples here because, for instance, on all these categories, 15 and 16 are a full 12 months. And I
Right.
thought I heard you say that 17 isn't even quite 6 months.
Well, it's through 6/14, June 14th
Right.
data, so
So
we
it-
still have the remainder of the year to
That's what concerns me. So if you just say that's half a year and I double it, isn't the trend going the wrong way?
Well, it could. It could.
Well, it's likely, isn't it?
The office visit, I'm catching that too. It looks like under office visit, you had 1,309
Well, on all of them.
in 2017.
So are you doing a January 1 to December, or are you doing their July 1 to?
This is calendar year.
This is
current
calendar.
calendar.
Okay.
Yeah, I mean, it just looks unusual because you see this trend from 15 to 16 in all of the years, basically. But then suddenly what I'm hearing you say is that we're going to reverse that trend dramatically in 17.
Does anything have to do with the grandfathering of the extra 6 months at all? Or,
Yeah.
or because of the
No, 'cause
calendar
these
year, I
are-
guess it wouldn't, would it?
These are per visits, right? So based on just an actual visit?
I would have,
I mean, it's
I
hard
mean,
to
if you look at
predict, but
inpatient hospital, I mean, even if you look at that and that were to double, have a hard time believing we had like our worst year a couple of years ago.
Right.
This wouldn't make sense.
Yeah, I
So
something
I have
like
a
that.
feeling that maybe this was run July to June 30th, but maybe something to check on.
So Joyce, you're saying that when you ran this report, you ran it January through December? And
yes,
then
this is incurred calendar
Incurred.
year for
Incurred.
15, 16, and then year-to-date for 17.
Right.
Because our inpatient hospital numbers aren't showing a significant increase.
For the current year?
For the current year.
Well, your report that you're looking at is going to be based on July to June. So
Right.
it's not really
This
going
is
to
different.
coincide with this, the HPA. Because this is run on a...
Right, I understand, but like when we talk about inpatient hospital doubling, you're talking about going from 3 million to 6 million. I mean, it's a really big number. And what caused part of our premium increase 2 years ago was an extremely large inpatient hospital, which I'm reading on this chart. So if I'm looking at that trend, we were nowhere near that. So that makes me wonder why inpatient hospital, if this is really truly half, it would exceed where we were in our worst year.
Yeah, maybe you could
That's
take a look
why-
at these. These trend lines don't make sense to me. They really don't. Because office visits, okay, 1870, 15, 1673, in 2016, if you follow the trend line, it's going to jump to over 2,600 in 17. So if that's the case, why?
Well,
Or is
I
this
don't
chart,
think it's not. I think
or is
that's
this
not
chart
real,
just
yeah.
not correct? For instance, when you look at routine wellness office visits, the benchmark's 529. According to this, we will exceed that benchmark in 17.
It's possible.
But so what happened in
But
17?
improbable, what happened?
Yeah, that's what I'm getting at. In 17, what I'm suggesting is that either this chart is wrong or something's gone horribly wrong in 17 to make
Well,
our numbers
just-
go the opposite direction.
But the data that we received from Gilsbar to this point is trending downward.
Correct.
So that doesn't make this, everything we have seen to this point
Yeah,
has a downward
it's-
trend.
Yeah, it's,
Yeah, but like I said, the report that we run on the HPA is a different date parameter. But I can go back to the actuarial team
It
and have
is
them
a-
But
relook
a
at this
decrease is
data.
still a decrease.
yeah,
You
you
can't
can go
make it a-
July to June or
a double.
December, or January to December. And if July to June is trending, going down all 3 years, but suddenly
Yeah.
it's not making sense. So,
I can have the team relook at this
Yeah.
and make sure that the date parameters were correct.
yeah.
Maybe re-present or
Sure.
re-email, so
Sure.
we can present it in August.
Okay.
If we're going to represent this in August, do you want to change any of the date parameters, or are we going to do calendar year?
Is it possible, Joyce, to run these reports from July to June each year?
We could, yes.
That's, in fact, I think that's what I asked for,
Yeah,
is July to June.
That would make more sense.
I could be wrong, but
I think
Well,
we talked about this on Friday.
This
And we
report would
talked
make a
about
lot
the
more
impact.
sense if that's how it
other
was
than it was
run.
coming.
Because then
in
there's
my
only
initial
14 days
report.
left, or 15 days left,
Yeah.
and then this accurately shows the trend we've been seeing. So maybe it could be that this report really was run July 1 to June 30th.
That's what I'm thinking.
That's what I asked for, was July
Yeah.
1 through June 30th.
Okay, I'll have the actuarial team rerun it.
Or look at it,
Sure.
if it is prepared from July 1 through June 30,
Then it's
Then it makes
accurate.
Then it makes
Makes
sense.
sense.
Yeah, then it all makes
right now it
sense.
makes no sense.
Gotcha, okay. We'll have it,
That's
do
why
you
you
want
pick
me to
July.
email it to you in between, before the next trust meeting, or wait until
Yes.
next?
I would like to see it
Good,
before.
yeah.
You send it to Mike, and then Mike can
Okay.
get it out to us.
All right, 3.11, report from Marcia on trust attorney billing.
So, referring back to, Madam Chair, referring back to our last minute meetings, we were discussing receiving all of the information from Kavanaugh, from our legal firm, and Mr. Rooney had asked me to look at all of that information and report back. Based on the information that I've received, and this is basically everything that we got, that I printed off, there was a copy delivered to the district in CD form, and then I have reviewed these and compared these to the billing. I'm going to recommend that this information be discussed under executive session because of the client, attorney-client privilege information that's in there.
In today's meeting?
Yes.
Or future meeting? Okay. So we can address that in executive session. Okay. All right, 3.12, annual report from Cerner, mentioned in the May meeting. We'll do our annual review at the next one, but you have information to report?
I do have a quarterly report and a WOW update for you today, but our big presentation in September will be a yearly review of the center and the WOW program. But I do, first let me give you a WOW update. We are in the middle of our final WOW appointments right now for the 16-17 year. We only have a few days left. The 30th will be the last day. In the fall, we had 571 people come through and do an initial visit. As of yesterday, we had 443 come back through, and which would be 78% of people have participated. We have 92 appointments still scheduled for the rest of the year. If everybody completes those appointments, you guys will have another great participation rate of 94% this year. As we've mentioned to you guys before, over 75% is a great participation rate in a wellness program. The trend is usually in the 60-70% for people participating in wellness programs. So 94, you guys really should give yourselves a pat on the back, a clap. This program is very successful, and we're very proud of it. The next program will start July 10th, and we'll have more about that, but we do a pretty quick turnaround. So the last appointment is the 30th. We kind of close the data. Our analytics team gets the data prepared for the annual trust meeting, and we do a reset on the program and get it going pretty quick in July. We will have more data as far as the biometric screenings, how people did, improvements, risk factors, things like that in the annual report in September once we're able to tabulate all the results. But any questions on the quick participation update?
Can you move that September up to August 2nd?
Not. I can ask, but due to the wealth of information that's going into this report between WOW, center data, ROI, VOI, some of the stuff we're trying to do with Guildsbar, I don't know if we can move that up. And we do have a representative that's planning to travel here from our actual analytics team, which is great to have someone here, kind of a numbers guy that will be here with us. And he's already planning to travel. You can always pass that on and see if they can move it up.
Because our next trust meeting is August 2nd, which means we have to turn around and have another trust meeting in September.
No, we would have.
We wouldn't have a September meeting, we have an August 2nd meeting.
Oh, I'm sorry, it was told September. I can take it back. don't know that we can have the data by the 2nd, but I will ask
You
tomorrow.
have to meet in August or September.
We can, when we get to that agenda, we can look at moving. I don't know that there's anything
I
that,
think there's anything critical.
well, what was tabled, that, does that have to be done by September 1st?
The approval of voluntary loss? It does.
So, yeah.
Can that be done via email? Does that have to be?
Could do a call.
Yeah, we can
Telephone.
post that and be here and that be the only item and
And
then call in.
there were some dates in September, right? That they were asking us to try to avoid the September 10th through. She said she emailed you the dates, Dave.
Who's she?
Sharon, my boss, Sharon Radovich.
Yeah.
The analytics guy, Noah Rennie is the analytics guy that's going to be with us. He actually has he's going to be out of the office at 9:10 through 9:21, I believe. I can ask tomorrow if we can up the date. I just don't know if it's
So
possible.
we're going to have to push it towards the end of September.
I don't mind asking them tomorrow, and I can try to get back with Mary or Dave or someone, but.
Yeah, that's okay. We'll get to that when we discuss.
Okay.
it.
All right, I do have a little bit of a quarter review for you guys. Now remember, our quarter would have been April, May, and June. We're only to June 20, I don't even know the date today. 21st. So our data only goes through yesterday, okay? But we did want to tell you a little bit about what we did this last quarter. Once again, thank you for your partnership, Cerner. We enjoy our partnership with you. I have Laura Shackelberg, who is also a nurse practitioner with me at the center. I'm Chrissy for you, those of you that don't know me. I'm the center manager and also a full-time nurse practitioner at the center. We love what we do at the center. We feel just fortunate to work at this great place to serve your employees and their dependents. If Laura will click, we'll kind of go on just a quick agenda.
Are we going to get a copy of this? Because I don't think this was distributed to anybody.
I can email it out. If you
And send it to Mary.
Okay.
Send it to me.
We'll email it out. Quarter in review, we just want to give you a little utilization report, patient satisfaction. We're going to go kind of over what we did on the wellness side, and then of course we like to throw in a little bit about quality care, patient experience, value on investment, and then open up to any discussion. Proven results. So this last quarter, as I mentioned, a little bit of a short quarter because we don't have the last days in, but at the center we've had 1,371 visits. Out of those, 82.8% have been employees, 17.2% have been dependents. Appointment types, roughly 157 have been same day, 86 have been an initial illness, 53 physical exams, 31 MA visits, which would be lab visits, 112 illness follow-up visits, 856 wellness screenings and follow-ups. Now remember, half of those are the actual biometric screening and the other half will be meeting with the coach to go over the data. So both of those are in that category. And then 64 condition management visits, which is going to be your diabetes, your high blood pressure, your high cholesterol kind of follow-ups and management visits. And then there are about 12 visits in there that are immunizations or DOT physicals, things like that that go into that total number. Quality management, patient outcomes. Once again, we do have a portal or a dashboard that we updates every night at midnight that we're able to go in and see visits real time, see patient satisfaction. For this past quarter, our satisfaction rate was 98% compared to the national benchmark of 80%. And then off to this right, you'll see some of the comments from patients. These are actual comments that people type in that we are able to upload and see. You can read these, but a lot of people say this is an invaluable service, helps me stay healthy, I don't have to add the burden of who I can go see, and will I even be able to get in on top of what's hurting or ailing me. A great plus, convenient, caring professional. My primary care physician was busy, did not take care of a physical for over 10 years. This has been a good experience for me and my wife. I've been coming to the Wellness Center for 2 years, and every time I come in, everyone is pleasant, professional, greet you by name, walk into the office. They have excellent service. I'm extremely glad of being able to have this service here in town. I am sick again. When you work with children up close, this happens. Last time was in March. I value this resource so much. getting appointments when you need them and getting well fast so you can get back to work. So that just speaks to that a lot of people want to get better. They want to get back in the classroom. They don't want to spend their time being sick and being out of the class. Some of the highlights in April, we did have our small cooking class at the Wave Center. It's a small group where we cook a healthy meal, and then they get to take the leftovers with them from all the meals that we cooked. We do have that coming up again next year, very successful. The response is great, people love it. We also had our 8-week small group weight loss group session called the Full Plate Diet that we did in the office. Had great success. Laura, the final results will come out in September, but out of the 10 participants, we had a weight loss of 20 pounds across the board. I think it was 2.8 pounds average per person. About 2.8 pounds, but of course this was an 8-week session. And we'll have those results in September, the final tabulation for you. But people really like this. We also have a lot of people interested for next year. We will do another session in September where we will open this. And this isn't limited. This year it was new. We only had 10 people do the first class, but we have a lot of people signed up that want to come in September and do it with us. And this is kind of one of those things that Laura and I fit our schedule to them. We asked the 10 people what worked best for them. Saturdays worked best for them at 9 a.m. So Laura and I met with them on Saturdays at 9 a.m. and did the class. It's an hour session each week. We shared recipes. Laura and I cooked meals for them from the diet to give them examples. So I'm excited to give you guys that result in September. We also did our skin safety promotion in April where we handed out a flyer to all the members, included lip balm to help prevent skin and sun safety, skin cancer, things like that. In May, we promoted men's health. Of course, school is kind of winding down. People are busy, so we don't offer quite as much May, June, July because everybody's out of town or enjoying their summer. But we did have men's health. We had the men's health workshop online. We did Wear Blue Day for men's health. And then June, right now, we're promoting physical fitness. We have flyers up in the center. We're talking about physical fitness, and we also have the online workshop on the wellness portal about exercise. So those are some of the things that we did this past quarter. I'm going to give Laura the floor to talk about our diabetic results.
Good evening. I'm Laura Shackelford. And so my couple of slides are talking about annually, we do one strong initiative. We set our goals for, we pick a chronic disease process or what have you to try to work on improving the overall health of our members. So this past year, we worked on making sure that our diabetic patients are well under control. It had a national benchmark at which we were already under to try to keep our diabetics at less than 9% hemoglobin A1C. So we shot for even to get that even lower to try to see who all was under 7. So as you can see from our initial readings of our 38 total patients in the fall, we had 57% who were in compliance, and then by the end of the time frame, 9 months later, I believe it is, we had 76% in compliance. As of the end of the program, we only had 2 patients that were at 9% or higher, and since then, one of those 2 has reduced even less and is now in the 7s, and the second person is down 2 percentage points, even though she's not quite at goal yet. So we really had good success with our diabetic patients overall this year. And it wasn't included in the slide, but I know it keeps getting mentioned, chronic illness management, chronic illnesses. So going along with this, I just wanted to recap that last year we had an initiative regarding our hypertensive patients. And we had very similar success then as well. At the beginning of the year, we had 52.8% of our hypertensive patients who were under control versus the national benchmark of 63%. And then by the end of the year, we were at 82.8% versus the national benchmark, which had also risen to 72. So we are striving to make improvements in our patients' health, especially in those chronic condition areas, which are the, as the slide says, the things that cost the district more, the conditions that cost more money. So one of the things that Cerner looks at is also value on investment. And when we're talking about value, of course, it does relate to dollars and cents, but it also relates to patient satisfaction and patient, the perception of value from the patients. So we brought in this particular scenario. One of our patients came in 2 years ago worried about weight. Obesity was not only a problem for herself, but also her family. So she started a program where she came in that had monthly visits and began a discussion about diet, exercise, what she could do, making small changes at first. And over the past 2 years, she's been very compliant, working hard, and has lost a total of 32 pounds. And she's maintained that weight loss, and she continues, maybe a pound a month, but she continues even now to follow her plan and follow the teachings that we've given to her. Along with that weight loss, her biometric readings have also become normal. So together we can accomplish great things.
All right, do we have any questions at all?
I have a question. If you have a question, go ahead.
Yeah, on your types of visits you had up there, do you know how much, on average, how much time you spend in each visit?
Depends on what the patient needs, I would say.
But each visit is scheduled for half an hour, typically. Physicals for an hour. And it's, of course, more or less. We kind of push, especially nice when we're both there, which is most days, because we can kind of catch as needs be between us. But they're scheduled as generally half an hour to an hour.
So most of the time, so you schedule them for 30 minutes, and do they normally last longer than that typically, or you pretty much?
Well, I saw a lady for pink eye today, and it was really 5 minutes. But yes, there are the times people come in and for physicals, usually 45 minutes to an hour.
Did you schedule your physicals for an hour?
We schedule it for an hour.
But so typically, if you have patients scheduled 30 minutes, there's not very many times you go over that in a 30.
Not really.
Not really, but you also have to remember a lot of our patients, too, that I want to stress, they come in for pink eye, but then they also say, I've got a cough and a cold.
Oh, sure.
Or I'm depressed, or school's stressing me out. So now we've gone from one problem to 3 problems.
Right.
Honestly, you probably know this out in the community, that doctor's going to say, I can't address that today. You were just a pink eye, I need you to come back. So that's another copay, another office visit to the trust. As opposed to us, if I know Laura's in the office with me and a walk-in comes in, I can dedicate a little bit more time to that patient because I don't want someone stressed about work and anxiety and depressed just leaving or saying, you need to go home and come back tomorrow. You know, I want to address that with them that day and not send them out without, you know, it being addressed too.
Like the pink eye lady today, actually she was here for a wellness visit. And she's like, you know, at the final I always say, do you have any questions? Oh yeah, well actually, so I'm like, okay, I've got time. Turn right around, let's see you again. So
to answer your question, we do, an urgent care is 25 minutes in our scheduler. Do they always use that amount of time? Maybe not. Sometimes they do, because we do a lot of education. We dispense meds, you know, so they're also waiting for us to mix an antibiotic for the kid and things like that. That does take time, especially with kids. You got to make sure it's the right dose and do your calculations. So sometimes it takes the whole time. Not always, but we don't turn people away either. So if someone walks in and I have a 30-minute slot on the schedule, I'm still going to work them in that time too. And sometimes people don't need the whole, like you said, pink eye 5 minutes.
Right. Right. And then on your full plate plan, was that just sort of like a little pilot that you limited it to 10? Or is that the total number of people that were interested in actually signed up to participate?
For the first class, the 10 were interested.
The 10 that were interested in that, there were more that were interested, that then for whatever reason did not end up committing and participating. We chose, the 10 people, 10 started 7 classes or more. So,
And there were a total of 8 classes?
Yes.
And we are interest again. So we are going to hold 3 informational meetings again in August. What participation or who is really committed, and if we're not going to turn anybody down. If we have 3 people that want to do it, we're going to do the class. So we'll start the sessions in September again.
And you're open, the center is open on Saturdays, right? Okay, so the classes that you were doing were on the normal hours?
But that was per what they wanted to do. So if this next group wanted to meet Thursdays at 5, we'll meet with them Thursdays at 5. So we let the group pick what time worked best for them.
Okay, and then you said 7 attended 4 or more. Do you know how many attended all 8?
That would have been
there may have been, I don't think there was anybody that attended all 8.
Except me and Laura.
Of course.
Yeah.
And, yeah.
I think
Most
there were
people
some that did 6 and 7, no.
I know at least 3 did 6 or 7.
Okay. And was there any makeup class or makeup visit or anything, or was it just those 8 weeks and that was it? If you made it, you did. If you didn't,
Well, we did some if they wanted to do a one-on-one session, they could come in and go over the book. And that was another thing. Cerner provided the books for the patients. They weren't out of pocket. So the fiber guide, the book, the participation guide was no charge to the patient.
and this was like a trademark for plate plan or something?
We have obtained a little bit of money for precepting students on a grant program, a nurse practitioner program in the state. So the money that we were awarded for that, we're dumping into wellness offerings for the patients. So we give that money. So the books, for instance, was some of the money that Laura and I obtained for precepting nurse practitioners.
So you got the grant for the precepting?
Yes, but we're giving that money basically to you guys. We're using it for some of these WAVE classes so that they don't pay for them.
Sure.
The books for the patients for this class, we're allotting that money to them from that grant money that we earned for precepting students.
So that's not something that the trust or that we applied for the grant. You applied for it as practitioners. Okay. And then on the conditions, I know we had talked before, and I went back and looked, and this was the month we were supposed to be getting some of that information. So it looks like it's going to actually be included in something else. But we had asked about 5 specific diseases, and if you could give us a detail on that.
Yeah, we did have a meeting this past week. What we're trying to do is mesh all the data between us and Guildsbar. There's a lot of particulars. I know Cerner on our end, those conditions, we are able to find out how many of our patients have that in the trend, or if it's getting better. But to get some of the outside claims is a little bit of an issue, and I think they explained today also some legal stuff that they're having to work out. Can you elaborate more on that?
Yeah, the Cerner folks said that there was no way they would sign on either a BAA or a non-disclosure agreement. So I think we worked it out that once we get the information over to Guildsbar, and Guildsbar uses the CPT codes for ICD-10 codes, then they will search their claims information and give me that data, at which point I will give it to Cerner, and then Cerner will look at that and see if they can mesh some of it up. The other problem is Cerner manages those cases for those people who come to the center. Guildsbar doesn't manage anything. Guildsbar just pays money. So they don't know whether it's being managed or not. They just get a claim in that says they went to the doctor for this particular condition. They have no clue as to what the doctor's doing with that.
Well, except for Cerner, I mean, you've got diagnoses in your visit note, right?
No, that's what he's saying. We're able to track our patients and what
And we
we're
can
doing.
get the same data from
But
Guildsbar.
Guildsbar can't. So, for instance, Guildsbar wouldn't know if my A1C was improving or how I'm doing. All they know is that I went to the doctor and they put a diabetic code. They don't know if that person's losing weight. They don't know if that person is losing their A1C, dropping, going higher. Now, Cerner, we can report that data, but Guildsbar can't for the people that are going outside.
But I think what we had asked was there were 2 different things we were trying to figure out that 5% increase in it would be matched or be based on improvements. And so we'd ask for those 5 specific diseases to see the improvement over that 5 years, and then not necessarily wanting to see improvements, because we would never be able, you're right, we'd never be able to get that from Guildsbar, but we could definitely find out and identify those 5 same diseases and see the frequency of visits outside of your center, so we can see, are our members going to you more for these diseases, or they're going outside? And that was really so there was two parts to it.
So we are planning to present on those conditions for you, what's going on in the center.
But you don't have it now?
No, that's going to be in the annual report. But then we are also working with Gilsbar to give you data on, visits in the center versus visits outside the center, using the codes like 99202s. What are we seeing in the center under that, like the same visit, what's the 99202s out in the community, to give you that comparison. And then we're also trying to see if we can work out something with our cohort group for Gilsbar to look at the cohort group's claims outside the center to kind of give you a comparison. If those people, because our cohort group is doing really well. They're improving, they're maintaining health. So we're going to kind of see if we can select that cohort group and see if they're going outside the center maybe at all, or if their claims have gone down and things like that outside the center. So
I guess I just want to make sure that the information that we requested is what, because I know it takes a lot of time to put all this together. And so there were several questions based on what the outcomes are and improvements over 5 years based on those diseases. And then we had the comparison of the actual CPT code, and then we had a comparison of those types of ICD diagnoses that would be treated in and out. So I just want to make sure that we've got all of those things being looked at. So I can, reaffirm that with Dave and make sure that my list matches the list that we discussed in the meetings. But that's what we were talking about. But that'll be what you're going to be doing in the annual meeting.
September is a good plan. It's going to be a pretty broad report.
So this is for the September meeting?
If they vote on September.
Depends on where we change the date once we move to that agenda item.
Okay.
And then on the 38 patients that you were treating that had a hemoglobin A1C, you had 38 diabetic patients that had
people that have listed us as their primary care provider who are being followed for diabetes.
38.
Okay, and so that would be hemoglobin above 5.1, 7?
Under 7 is in control,
right,
according to the American Diabetic Association. That's what we follow. The Endocrine Society is about the same, what they want.
Right.
So actually, I'm going to have to look back at the slide, but in the beginning, that first bar,
right,
I believe it was 50-something%, those were already under a 7 to begin with. The next bar, we even increased those, so people dropped from the 7 to 9 group into the 7 group. So we went up to 70%.
Okay.
And then, so that shrunk our 7 to 9 group. Then we only had 2 that were above a 9 at the end of the year, which would have been January to December of last year. 2 were still and not above 9. However, one of those patients is 9. He has now dropped to a 7.4 since this.
But they started above 9?
They did. And then one is Laura's patient who she referred to that went, she was a 14. She's now what, 10, 11. So we're seeing improvements. And if we did this chart again, mid-year or at the end of this year, we would probably see those 2 back. We wouldn't have any above a 9.
Okay.
Even though the ADA says less than 7, the national benchmark is how many patients do you have under control at 9 or less.
Right.
Even though, that's just their benchmark number. So when we looked at the 9, we were under good control. That's why we started saying, okay, yeah, but we have quite a few that are between 7 and 9 that could be better. So let's just for our own, gonna do good, worked on that.
Okay. So questions?
I know how overwhelmed new staff members are, and I know some teachers are hired almost the day before school. What is the procedure in the district? And Chrissy, you may not be the one to answer this. It might be Mary or Gary or mine, but what's the procedure for explaining their new employees' benefit and the wellness center?
We have an open Know Your Benefits seminar right after our Welcome Back assembly in the high school. This is a 2.5 to 3 hour long meeting, and all the new
It's the last thing teachers want to go to.
It's all part of the new hire orientation. It's all part of their week of training.
Yeah.
So they are required as a mandatory meeting.
Okay.
And they all attend that to learn all about their benefits.
Have you noticed whether new staff members actually, a large percentage actually start showing up rather quickly, or does it take them a year to get it figured out? No, it doesn't.
It's rather quickly, but I would say part of that's the WOW program. But it's pretty quick, especially with sick visits. But, you know, the other day I had someone call and say, oh, my friend said, you know, come to you guys right away for a call. So staff are talking too. I mean, some of the older staff that have been here, they are making the other staff aware, hey, you have a health center you can go to if you need to. We attend the new benefits orientation as well and do a presentation. We try to send out as much emails, but a lot of people get inundated with emails and they delete a lot, I'm sure, out of their box. But emails do go out about the wellness center and the program. The insurance reps were, in the past, have also hopefully passed down stuff about things going on with the insurance.
I was thinking that might be a really good responsibility for the insurance reps to, a couple of weeks later, to go about the new staff members. But at the high school, that would be too large of a job to carry. But there's some other staff members who I'm sure could help you do that. But maybe it should be in an organized way.
Speaking to that, we have a couple of things scheduled for this next year, and one is for us to just go and join a lunch to meet, you know, to eat our lunch in the cafeteria, like maybe at the high school, the middle school, which are the two largest schools, just to be there so that people who haven't been in the center can, like a, you know, on our poster board, come and meet us, kind of thing. Also, we are doing a new little initiative that's for new hires only, kind of a little benefit thing, you know, come in and get a physical, establish a hair, to really try to target that group of new hires as well.
Communication is everything, and I'm so pleased that you thought
That
we
is kind of our focus.
And we do. I mean, just quickly, we do have derm screening. There's a new derm physician's assistant in town who I'm waiting on his phone call to confirm, but he does want to do some free derm screenings for us this year. So I have that on, you know, coming up in the works. So we'll definitely communicate once he confirms to do that for us. Of the full plate, like we said, the WAVE cooking classes are coming up next quarter. Pro Therapy is going to come do a talk in September at the center on back safety, back health, ergonomics. I'm going to teach chair yoga. I'm not the most graceful, but I'm going to teach that at that class. We also have a great program that we've kind of talked with the staff about, Passport to Better Health, is going to kind of run along with WOW. And I'm really impressed. We've created a fun little passport that we're going to give to every employee and their spouse. It's got 10 stamps they can collect throughout the year for important preventative things like your annual exam, your skin, your mammogram, your PAP, your prostate screening, your colonoscopy, if you attend a wellness class, if you go on the portal and do a class in the portal. So if you get 5 out of 10 stamps, their name will go into a drawing for a raffle at the end of the year. So to try to encourage preventative care, encourage utilization of the center. We have that kind of fun program coming up this year too. I'm really excited about that. I should have the passports hopefully in the next 2 weeks, kind of printed from Cerner to start distributing out. We also have, of course, our monthly wellness theme and flyers and activities that we try to do every month. So we've got a lot going. If you got any suggestions, we'd love to hear those as well. You're welcome to call or email the center if you have any ideas for a monthly theme or a class that you'd like to see. All right, anything else? Thank you guys for your continued partnership.
Madam Chair, members of the board, I just want to make one correction. We keep hearing these 5 diagnoses, and I'm looking at the April 28th trust meetings, and there are 4: diabetes, BMI, hypertension, and hyperlipidemia.
And hypercholesterolemia.
That's not in the minutes.
Yeah, it's actually on the video, so if you go back and listen to the video.
Hyperlipidemia and cholesterolemia are the same.
No, they're actually not. They're different diagnoses. So I just wanted to see if you had, you know, if you're tracking them the same. But
I mean, I know they're 2 different diagnoses, but we
they
consider
are
them the same
different
condition.
Huh?
We consider them the same condition. So, but I had heard tossed around metabolic syndrome at one point. I don't see that on here, but was that the 5th one, metabolic syndrome? Or
Everything was videotaped on that recording. We did talk about metabolic syndrome and hyperlipidemia, hypercholesterolemia. I'll go back and watch the tape.
Sorry,
I'll
it
go
wasn't
back.
in the minutes, so I just,
Okay.
because
Well,
when I used these minutes in contact with both Cerner and with Gilmore.
I'd be happy to go back and review that video and let you know what it says.
De facto, as a provider, a practitioner, whether I code hypercholesterolemia or hyperlipidemia, I would give the person with elevated cholesterol would either get one of those two diagnoses.
Absolutely.
Like, we kind of pick one and kind of stick with it, if that makes sense. So to us, they're interchangeable.
Yeah. So in that one category, we should be including all of those ICD-10.
In that one hyperlipidemia.
So I'm not questioning, absolutely, I mean, you're the medical professional, you're going to make the decision on the diagnosis. That was never a question. Those were ones that I had just brought up, and again, I'll go back and make sure that I confirm the ones that were in there.
But for the statistical purpose, we should probably include all people with both the ICD-10, hyperlipidemia and hypercholesterolemia, in that high cholesterol group.
I agree. Absolutely.
Any further questions for Sir? All right. Do I have a motion to move to executive session? Yes, as soon as we move.
So moved.
Second? Second. All right, we'll take a 5-minute break before we move into executive session.